Hello and welcome to CQC Connect, the podcast from the Care Quality Commission. My name is Annabelle Stigwood and I'm the joint lead on the CQC's Inequality project, which is looking into the concern that GP practices led by GPs from an ethnic minority background receive poorer CQC ratings or regulatory outcomes. So this is our second podcast on the project. The first one talked about how the project came about and what our aims and objectives are, and a link to this can be found in the podcast description. The literature review and early findings of the Inequalities project suggest that ethnic minority GPs often work in areas of deprivation, working with patients who experience more health inequalities than the national profile. And so today we're going to be looking at health inequalities in general and how they impact on the ability of general practices to do their jobs. I'm joined by Dr Faizan Ahmed, National Clinical Advisor for the CQC in Primary Medical Services and Integrated Care. And also our special guest is Dr Bola Olowabi, who is Director of Health Inequalities at NHS England and NHS Improvement. So Bola, could you start by briefly explaining what we mean when we talk about health inequalities and why a focus on health inequalities in health and social care is so important?
Thank you, Annabelle, for having me. It's great to join you on the podcast today to discuss this really important subject of addressing health inequalities. And I really find the King's Fund's definition of health inequalities incredibly helpful, which describes health inequalities as unfair and avoidable differences in health across populations and between different groups within society. I find it a very useful definition because it firmly asserts that health inequalities are not inevitable, and also it gives a sense of hope that actually we can do something about them. And then moving on to why is it important that we do address health inequalities, both in the dimensions of healthcare and the wider determinants. I think it's important because if there's anything that the pandemic has done, it has exacerbated and highlighted the health inequalities that pre-exist actually and predate the pandemic itself. And I think that exacerbation then makes it absolutely imperative that our common collective legacy beyond this pandemic must be one of addressing those health inequalities. That is why it matters now.
Thank you, Bola. Faizan, we talk about health inequalities in the CQC State of Care report from 2021. So what are some of the headlines from this?
Thank you, Annabelle, for having me on to speak again about this most important of topic matters. It's lovely to hear from Bola, particularly. She's got very much a can-do attitude, and that very much chimes with the response that hopefully the CQC will have as we go forward. She rightly says that the pandemic has served in two ways. One, to very much bring forward and centre the issue around health inequalities and the wider determinants that lead to that, but hopefully will also serve as a catalyst for us to take action forward. And as you rightly say, Annabelle, only recently we released the State of Care report, and it makes humbling reading, really. Particularly there's a section within that we've included where actually, as the title intimates, that the health inequalities have been further exposed during the pandemic, and the sort of shocking statistics that have been shared across the health and care system. And I know Bola will speak about this as we move through the piece, but there's an inexplicable link between deprivation and some of the poorer outcomes as a result of the pandemic. And I think probably the most shocking of all is that in terms of the mortality rate in those deprived areas, they're 2.5 times, you're more likely, 2.5 times more likely to have died from COVID if you're in a socioeconomically deprived area. And akin to that, and leading from that, if you're a person with Black and Asian heritage, your rate when compared with your white counterparts, your white neighbours, is double the risk of death from COVID. And that simply cannot be a state of affairs that we as a system tolerate. And it's interesting to note that those areas that are deprived are often led by GPs from a Black and Asian minority ethnic background. As Bola said in her introduction in terms of health inequalities, whilst the pandemic has played a vital role in reaffirming the importance of tackling health inequalities, what it hasn't done is expose anything that we weren't familiar with before, and some of the issues have continued. So access, particularly for people whose first language is not English, continued and continues as part of service recovery. And when we turn to recovery post the COVID pandemic, particularly in relation to vaccine uptake, we know that people from particularly black ethnic groups are much less likely to take up the vaccine offer as it stands, whether it be the initial programme or the current booster.
Thank you very much for that, Faizan. So reflecting on that, Bola, how do you think that system partners can work together to respond to these and address these health inequalities?
Thank you, Annabelle. Just building on Faizan's comments there, looking at the really important piece of work that you've been doing. I think my reflections would be anchored within some thoughts about the roles of the NHS in tackling health inequalities. And we've said within the NHS long-term plan that we can't treat our way out of health inequalities, which is true. But that is not an absolution of responsibility. Actually, there are 4 key roles that the NHS can play very powerfully in addressing health inequalities. And I will use that as a springboard to then address the specific question of how system partners can collaborate in this space. So first of all, the role of the NHS as a commissioner and provider of services. So it is within the purview of the NHS to configure our contracts, our service specifications in a way that addresses our vision for tackling health inequalities, which is exceptional quality healthcare for all by ensuring equitable access, excellent experience, and optimal outcomes. So the first role of the NHS in tackling health inequalities as a commissioner and provider of services speaks directly to that vision. Secondly, there is the role of the NHS as an anchor institution. So in many of the communities that we serve, the NHS is the abiding presence. So when many other organizations and services, for whatever reason, cease to exist, the NHS tends to be the institution that remains. And therefore, there is a powerful role that the NHS plays as an anchor institution in addressing the wider determinants of health. So housing, education, employment, household income. And within that space, there is an opportunity, therefore, for the NHS to work with other system partners in affecting change in relation to those wider determinants. And of course, there is the role of the NHS as a key player, key partner within the integrated care system. As the integrated care system kick into action on a legal basis from April 22, there is a role that the NHS can play as a partner with our local authority colleagues, with our health and well-being boards, with our voluntary sector and enterprise organizations, as part of our duty to collaborate, because that's what the Health and Care Bill says. We have a duty to collaborate. And that duty is a very powerful lever for us to collaborate with our system partners and begin to drive improvement across those huge, wider determinants of health that drive health inequalities and are beyond the purview of the NHS as a lone actor to effect meaningful and lasting change. And so that is the space within which I think we have the greatest contribution to make in collaboration in tackling health inequalities.
Thank you, Bola. So that nicely leads me on to ask Faizan, as regulator, what power or influence does the CQC have to make change?
Thank you, Annabelle. And as before I dive into that question, and Bola's absolutely right about how rooted the NHS is within our communities, and we mustn't forget, particularly when we're referring to some of our most deprived communities, often the GP service is very much the front face of provision within that local system. In terms of your question, a really interesting one, and I think that the perception certainly amongst the provider community is that the regulator exists really to be a punitive body to them, and we often forget that actually the regulator's role is not just simply to be an observer, to provide commentary. And what's lovely about the State of Care report, we're quite clear when we say that whilst there is some recognition across systems, as Bola describes the new integrated systems that are establishing and hopefully will establish to good effect, actually just tackling health inequalities hasn't been a priority across the health and care system. And that has to change. One of the intrinsic roles of the regulator is to, one, absolutely help systems to identify those inequalities, both evident and hidden. It's often that through our work on the ground, whether it be primary care inspections or other inspectorates, that qualitative data from service users and patients often highlights and identifies inequity that just hasn't been referenced or found in other domains. And that can only happen because we're an independent voice, we're an independent body. And although Bola and I are sharing this space at this moment in time, we obviously represent two significant stakeholders in this space. And so if our role is as regulators to help identify, it can't simply be that, as I say, it can't be just about holding the narrative. It's got to be active in driving up the quality of standards across the system. And there are ways in which we can do that. We're developing our new inspection methodology based on our new strategy, which will be much more inclusive, but it will also be receptive in a way that it hasn't done before. If we speak about our communities, and then again, we highlighted that whilst primary care became incredibly digitally focused as a way of managing demand, that wasn't the right thing for everybody and every service user, and we've got to get that right.
Yeah, thank you, Faizan. So reducing inequalities in people's outcomes is a fundamental part of CQC's new strategy. What our findings are showing is that there are things that we can do as regulator to support practices to address these health inequalities. Part of that is in relation to understanding the context that practices working in areas of deprivation are working in. Often the outcomes of their patients, their patients don't represent the national profile. They're often have poorer health outcomes, and we as regulator, we need to have better understanding of that context. And then we need to encourage improvement, and through understanding that context, it will enable us to better work with our system partners to encourage improvement. But I think the first step is understanding, and then the next step is finding ways to reflect that without compromising on outcomes for patients who use services. So Faizan, as you mentioned, one of the things that we've heard through the Inequalities project is that quite often practices in areas of deprivation are doing innovative things to meet the needs of their practice population, which perhaps aren't being captured in our current methodology, or the way that we inspect, or the way that we assess. So what we're doing through the Regulators Pioneers Fund is we're developing a toolkit for practices to use to help them to evidence their innovation through our regulatory systems. We are working with Yorkshire and Humber Academic Health Science Network to develop this toolkit, and they are currently completing field work whereby they're talking to grassroots GPs and understanding their experience of trying to evidence innovation through our current regulatory processes, and finding out what's going wrong and where we can improve, so that we are capturing those innovative approaches and sharing those finding means to share those with other practices, so that we can improve the health of the practice populations. So Bola, we talked about what system partners can do to better work together to address health inequalities. What support do you think that providers need to make these changes?
Annabelle, it's been great listening to yours and Faizan's reflections, especially stemming from the Inequalities project. And before I come directly to that question, I just want to say what a pleasure it is collaborating with your good selves and the CQC on the Health Inequalities Pioneer Fund. It really is a brilliant piece of collaborative effort, which I believe we can build on as we go forward. And I mention that because when we think about what providers will benefit from by way of support in addressing health inequalities, I would say, first of all, there's something about signaling. And I think the fact that the CQC as a regulator is signaling its commitment in this space, both in terms of the work that you've been leading, Annabelle, the Inequalities Project, and also in terms of the Health Inequalities Pioneer Fund, and the CQC's own strategy. I think those three processes and documents are playing the vital role of signaling. And coming from the regulator, that's really important when you're a provider, because what it says is that health inequalities is a matter of strategic priority to the regulator. And that message is incredibly enabling. I think in addition to signaling, there are perhaps three other things that providers will really benefit from as they tackle the challenge of health inequalities. There's something about capacity, being able to build the capacity to respond to what often feels like the most important day job, but to do so in a way that hardwires tackling health inequalities into the approach. So I think there is a capacity issue workforce-wise. There's also capability building. So how do we equip our providers with quality improvement capability that enables them to make inroads in this space? And it's quality improvement capability across 3 dimensions. One is about using data to drive improvement, so that data is not just used for the purposes of assurance, which is our traditional relationship with data, but actually building capability to engage with data as a way of driving improvement, whereby we actively draw virtuous circles of data, whereby the data gives us actionable insight of what we can do. And those insights then drive interventions. And from those interventions, we achieve improvement and intelligence about what works. And we go around the loop again. And then the second QI capability is a strengths-based approach, speaking to your points, Annabelle, which is, a lot of our practices that are in our most deprived communities, they're not bags of needs. They have unique strengths that we really can build on, but we have to ask the right set of questions to get to those strengths. So there's something about a strengths-based approach. And finally, co-production. Co-production with people and communities as a legitimate quality improvement exercise. I think that's the other thing in terms of capability building. And I think from the regulator's point of view, what would be helpful and useful to providers is to create an enabling regulatory environment in the way that you've both just been describing. And what does that enabling environment look like? It looks like what you were saying, Annabelle, a contextualized assessment framework that recognizes the context within which people are operating and may account for some of the things that we find on inspection. An enabling environment not only looks at the provider in isolation, but the system in which that provider is operating as well. And finally, an enabling regulatory environment is one that recognizes and appreciates innovation and improvement, as you've both been saying, not necessarily purely the ability to demonstrate impact, but actually recognizing that people almost always are on a journey of improvement and acknowledging the journey, not only the destination of where we find people on the day. I think all of that combined will be a composite suite of support that will enable providers.
That was fabulous. Thank you very much, Bola. I've written down some of what you've said there. I love the enabling regulatory environment, and encouraging improvement is something that we are always striving to do. So thank you so much. Unfortunately, that's all we've got time for today. I would really like to thank my guests, Dr Faizan Ahmed and Dr Bola Olowabi. You can keep up to date with the CQC's work on tackling health inequalities at cqc.citizenlab.co. Just follow the link in the podcast description. But until next time, thank you very much for listening.